Hi students, this is Dr. Tatum again. I'm going to start on slide 26, and we're going to talk about the recurrent premature dilation of the cervix, also known as an incompetent cervix. So this is defined as painless dilation of the cervix in absence of uterine contractions. So basically the cervix is incapable of supporting the weight of the growing fetus and pressure of the growing fetus, and it results in expulsion of the products of conception during the second trimester. So it is a late miscarriage. Risk factors include cervical trauma, lacerations, or if it's been a multiple gestation pregnancy, that could be a potential risk factor. Diagnosis is based on the patient's history. If she's had short labors in the past, that could very well indicate an incompetent cervix. If she's had reoccurring loss of pregnancies, that's another diagnostic factor. We use ultrasound to help us diagnose and visualize the length of the cervix. If the cervix is short in length, so meaning if it's less than 25 millimeters in length, and we potentially see some cervical funneling or even effacement, so thinning of the cervical os, those are all diagnostic factors that we use to evaluate if an incompetent cervix is present. One thing I want to bring your attention to is the prophylactic cerclage here. This is basically a fibrous mesh that's placed around the cervical os to constrict it. So it kind of holds the cervix together, basically, and it supports the weight of the growing uterus and fetus. And so this is placed at 11 to 15 weeks gestation. We tell her she'll remain on bed rest for a few days after the cervical cerclage is placed. And then we tell her to avoid intercourse until her post-op check. So each woman's care is very individualized. It really does depend on her risk factors. Most women will keep this in place throughout pregnancy, and then those that are going to have a vaginal delivery, they might remove it at around 37 weeks gestation. Some might wait until labor begins. It depends on the care that she needs. Some women that will undergo a C-section might just keep that cerclage in place. So all of those things are things that you might see. It's always good to educate her on the signs and symptoms of preterm labor, rupture of membranes, and infection. All of those things need to be addressed with her as far as patient education goes. So if I go to the next slide, maybe, there we go. So you can see them inserting the cerclage itself. And again, if you look at B, you can see here that this mesh basically closes off that cervical os. It constricts it. All right, let's move on to an ectopic pregnancy. This might be something that you guys have heard of. Basically, this is the abnormal implantation of a fertilized ovum outside the uterine cavity. This usually takes place in the fallopian tube, and you can see that 95% occur in that fallopian tube. The largest part of the fallopian tube is called the ampulla, and this is where a lot of the implantations do occur. However, implantations can also occur in the abdominal cavity, on an ovary, or even in the cervix itself. You can see that an ectopic pregnancy is responsible for 10 to 15% of maternal deaths, most often in that first trimester, and it's one of the leading causes of infertility. If she has one ectopic pregnancy, it does put her at risk for another ectopic pregnancy if she wishes to have another child. Some of the risk factors associated with an ectopic pregnancy include pelvic inflammatory disease. If she's had any history of sexually transmitted infections, some of those sexually transmitted infections can cause pelvic inflammatory disease, which puts her at high risk for ectopic pregnancy. And also any use of an intrauterine device can put her at higher risk as well. Oops. All right, so let's look at clinical manifestations. So there are some classic signs and symptoms. There are 3 specifically. So abdominal pain, A lot of times this is a dull pain at first, and then as it progresses, she's going to complain more of colicky pain or even sharp stabbing pain as that fallopian tube stretches during the growth of the fetus. We also we also have to ask her about her menses. So has she had any delayed menses? Has she had her period? When was the last date of her last menstrual cycle? And then if she has any abnormal vaginal bleeding, usually spotting does occur within 6 to 8 weeks after her last menstrual period. So the big thing here is I want you to try to visualize where the implantation could occur. If it is in fact in the fallopian tube, that fallopian tube is going to stretch and stretch and stretch until there's a potential rupture. And if that rupture occurs, then we have to really watch for signs and symptoms of hypovolemic shock, just because there's going to be a large amount of bleeding in that abdominal cavity. So go back and reflect and review on what your signs and symptoms of hypovolemic shock are. If the rupture does occur, she might have referred pain from blood irritating her diaphragm up in her shoulder, and then maybe even nausea and vomiting after rupture of the tube itself. So how do we care for this? Well, this is a disease process that is incompatible with supporting pregnancy. And so that's why you're going to see pregnancy loss in that first trimester. It's huge. But what we could do is a salpingostomy. And basically this is making an incision into that fallopian tube, removing the tissue, and then letting it heal by secondary intention. So we don't suture the tube back in place or together. We allow it just to heal on its own, and that's going to create less scarring. And hopefully that in turn will aid her in not having any or less likely infertility problems with her next pregnancy. The next one is salpingectomy, which is the removal of the entire fallopian tube itself. So those are some possible treatment. Methotrexate, we use this. This is a medication that we can give if the tube is unruptured and the mass is less than 3.5 centimeters in diameter. If they confirm by ultrasound that there's no fetal cardiac activity, then we can give this. And then we also confirm that the human chorionic gonadotropin level is less than 5,000 international units. So that's when we can give methotrexate. It's safe, effective, and it is also cost effective. But what it does is it inhibits cell division and enlargement of the embryo. So it destroys rapidly dividing cells. And it just prevents the rupture of the fallopian tube itself. Hopefully we can preserve the tube, and that's the goal of methotrexate. Again, future fertility should be discussed due to the high rate of reoccurrence. And then a lot of times we want the body to heal. So we want her to have at least 3 menstrual cycles to allow the body to heal before she could have another baby again. So we want her body to heal properly. All right, so this next slide just shows you some of the different regions where the implantation can occur. Again, the ampular region is the largest region of the fallopian tube, and that's where many will occur. But you can see also the ovarian, abdominal, cervical areas are also sites. All right, so moving on to placenta previa. So this is when the placenta abnormally implants in the lower uterine segment of the uterus near or over the cervical os instead of attaching to the fundus or the top part of the uterus. So the placenta is very low. So the placenta can actually cover the cervical os completely, partially, or very marginally. So there's different kind of forms of placenta previa. This does result in abnormal bleeding, specifically in the 3rd trimester of pregnancy, as the cervix begins to dilate and efface. So you can see here there's complete placenta previa. So this is when the placenta fully covers the cervical os. There's partial placental previa, which is when the edge of the placenta is close to the cervical os or only partially covers the cervical os. And then there's marginal placenta previa, which is a low-lying placenta. So when the degree of the placenta in relation to the cervical os cannot be determined, we call that a low-lying placenta. So the majority of these cases, it has not reached the cervical os yet, but it's very, very close. All right. So you can see as far as instance and etiology goes, most likely this occurs in multiple gestations, usually maternal age greater than 35 to 40. If mom is a smoker, if she's had a history of placenta previa, or even a history of C-sections or miscarriages due to scarring, she is at risk for placenta previa. As far as clinical manifestations go, painless bright red bleeding usually occurs in the second and third trimester. Most are diagnosed by ultrasound before this bleeding does occur, though. So basically, the bleeding is that disruption of blood vessels within the placenta itself that occurs with stretching and thinning of that lower uterine segment. You're going to see that more in that third trimester with that stretching and thinning of that lower uterine segment. As far as maternal and fetal outcomes go, this is associated with maternal morbidity and mortality. Complications include premature rupture of membranes, preterm labor, abnormal placental attachments, as well as postpartum hemorrhage, infection, or even thrombophlebitis. Fetal risks include malpresentation, so a baby's not positioned correctly, and fetal anemia. And this most likely occurs just because of maternal blood loss. Think about hypovolemia. If she's losing more and more blood related to this previa, she is going to become more hypovolemic in nature and also anemic. And that's where you're going to see fetal anemia come in. So then we worry about intrauterine growth restriction on top of that. And as I said before, preterm birth. So letter A here shows where this placenta is, and it is completely covering that internal os here, the internal cervical os. So this is a complete previa. Letter B shows the placenta only partially covering that cervical opening here. You can see it kind of extending through here. So we would say it's marginal. It's marginal in nature, it's low-lying. It's not completely covering that cervical os, but it's very low and maybe a little bit partially covering that cervical os. All right, as far as diagnosis and medical management goes, as I said before, ultrasound is going to detect placental previa. Most can be detected before bleeding actually occurs. So any woman with painless vaginal bleeding after 20 weeks of gestation should be evaluated for previa, period. As far as management goes, observation and bed rest are warranted. So if she is less than 36 weeks of gestation and has reassuring fetal heart tones and that bleeding becomes mild or stops, and she's not in labor, she might be hospitalized for a short period of time just so we can assess fetal heart tones and also the activity of her uterus. Most likely she's going to have IV access during this time. So if she bleeds more and more, then we have IV access available to us. If she is less than 34 weeks gestation, then we give steroids, so corticosteroids to mom, just so that we can mature fetal lungs. So betamethasone might be given if she's less than 34 weeks gestation. If bleeding does stop, then she's usually put on bed rest with bathroom privileges. We absolutely want to stay away from vaginal exams. So no vaginal exams during this time, no rectal exams, and nothing in the vagina during this time. It's just so important. If they accidentally did a cervical exam and they didn't know that previa was present, just think if you are messing around and trying to feel for any cervical dilation, you could put your finger up towards that placenta and potentially injure that placental tissue. So that's why we say no, no, no vaginal exams during this time period.